Okay, I guess we're recording this. So thank you everybody for attending this webinar. We're going to be discussing peripheral nerve stimulation and really kind of patient education that's going to be valuable to that, as well as patient selection for these therapies. So in the interest of time, making sure everybody gets out of here on time, we're going to go ahead and get this started. My name is Mortaza Rabi'i, or Mort. I'm a nurse practitioner out of Kansas City, the Kansas City area. Work in a high volume interventional pain practice. And I am kind of the oddball out tonight as the moderator. I get to learn a lot because we are not a heavy PNS practice at all. So there's a very good likelihood that I will be asking a lot of questions of the other panelists that you may have yourself. If not, there will be plenty of opportunities as well for you to ask questions. We'll try to answer those as we go along. So I've been in practice for about 4 years now. Prior to pain management, I was in orthopedics for about 10 years. So I'm going to pass it on to Nicole and Patrick.
Hi, my name's Nicole Bush. I am an advanced practice nurse out of Austin, Texas. I have been doing interventional pain management for 6.5 years. I currently work in a practice that is both orthopedic and has a pain management service line as well, which is what I work on. Prior to that, I was a hospitalist at one of our major hospitals here in Austin.
Hi, everyone. My name is Patrick McGinn. I'm a physician assistant in an interventional pain practice in central New Jersey. I've worked in the pain world for about 8 years. I'm very, very excited to be on this webinar, because I think hopefully you'll all see as we get through this webinar that the PNS is become such a, important therapy that we can all sort of integrate into our practice. So I'm looking forward to this webinar.
Okay, thank you guys. So our learning objectives for the evening. So we want to kind of highlight and be able to list the most common indications for PNS. So what kind of conditions are these devices ideally meant to treat? Also looking, where does this fit in the treatment algorithm? I don't know about you guys, but there are so many treatments that we have nowadays. We've gone far beyond 3 epidurals, a radiofrequency lesioning, a couple gabapentin, hydrocodone, now go see a surgeon, or steroid injection in the knee, go do some physical therapy and go see a surgeon. Is sometimes, unfortunately, it can be a little overwhelming, the number of different treatment options that exist out there. So really want to hit home on how this fits into or could potentially fit into your practice. We will discuss briefly the different commercially available peripheral nerve stimulation systems out there, whether it be temporary versus permanent implant. And also a topic near and dear to my heart, and as I'm sure it is for everyone that's attending tonight, is looking at the patient education aspect. How do we translate this therapy into a language, into something that the patients understand and appreciate, so that we can set them up for success in any trial or temporary device, but also certainly for long-term success with any permanent device that they may have. So patient selection, we try to do this kind of looking at it, how you would see a patient coming into your clinic. So the patient comes in, okay, how are you identifying this patient as somebody that would be good for peripheral nerve stimulation? Going through the workup, how you would identify and work them up for the device, ultimately how you would educate them, pass them on to your surgical colleague or your physician colleague, and then take care of them long-term. So I guess, Nicole, ladies go first. So how do you determine when a patient is a good peripheral nerve stimulation candidate?
So currently, peripheral nerve stimulation is recognized by our insurance companies for chronic pain. It is good for anybody, actually, who has any pain management in adults for severe intractable pain in the peripheral nerve of a peripheral nerve origin. National guidelines will tell you, do not really have a recommendation as far as what is considered chronic, although historically we have seen that it's defined as 3 months or more. They must have failed conservative therapy, which I know we will talk a little bit more about that later for sure. But the thing that we do need to be mindful of as far as who is a good choice, it'll also be dependent on what your local guidelines are in your state for what is considered chronic and what is considered intractable. Some are more strict than others. Here in Texas, we don't really have any. So chronic pain, having failed conservative therapy, anybody who is like a post implant is a great fit for that. But literally, even if you have not had a surgery, this could be good for you. What do you think, Patrick?
Yeah, I mean, I think that, kind of as I already alluded to, PNS is kind of exploding in the pain world. So I think that, these patients are probably already in your practice, or, maybe they're, referred to you from some type of specialist in the community. A lot of, since there's such a broad indication for PNS, I think it's also trying to gather those referral sources, which I think we'll talk about, but, educating these other specialists, and letting them know that, hey, that there's patients that could benefit from some type of PNS system. I think that, I think we'll get a little bit more into it later, but patients that, maybe wouldn't be good candidates would be those that, maybe compliance, right? Maybe aren't, have other medical comorbidities, are on blood thinners or anticoags that they're unable to stop. Or maybe, they're not so, up to date with maybe sometimes the user interface that some of these companies use, even though most of them are pretty straightforward. So I think that, there's a lot of patients that could benefit from this modality. And kind of like Nicole said, I mean, insurance always plays a role. So we have to, sort of ensure what the local guidelines, state guidelines are, which is kind of interesting to hear, how much it differs from state to state.
So just to piggyback on that, as far as things that would prevent us from recommending PNS for someone, I agree. For the implantable therapies, particularly being anticoagulated and being unable to come off of that anticoagulation for implant is definitely a thing. If you have a cancerous lesion on the nerve that is going to be stimulated, this will not be for you. For those that require MRI imaging, that's tricky. And we'll talk about that a little bit more later. The temporary or the 60-day treatment that is offered out there right now is not MRI compatible. So if your patient knows that they need to have frequent MRIs and will be falling into that 60-day period, it will not be for them. However, for the implantable therapies, a lot of them are MRI conditional depending on placement. So that's something to think about as well. I know for the implantable therapies, too, like if you have an ICD or a pacemaker, that will be a contraindication for using an implantable therapy. And if you are exposed frequently to diathermy, so like if you're working in a surgery, an operating room, and you're frequently exposed to radiation, that might not be it may risk frying the leads, which would not be a good choice, right?
I think one of the things we forgot, I don't know if we said, but these stimulators or PNS devices are there's for craniofacial pain. So that's one thing. So depending upon, indication or what peripheral nerve you're trying to target, none really have, sort of on-label FDA approval for craniofacial pain. So that's just something to be mindful of.
That's fair. As far as I'm to understand, the only one that is approved currently for head and neck is the 60-day treatment, as opposed to the implantable devices, although people have used it off-label before. And I think, Patrick, you might have mentioned this too, but definitely having a good support system for whether it's the 60-day treatment or the implantable therapy to help you with recovery or bandage changes if necessary.
Yeah, and I think anytime you're implanting something, or whether it's temporary or permanent, there should be maybe some sort of a neuro psychological evaluation. Maybe if you think the patient sort of doesn't, like we said, the resources, or maybe they don't sort of have the I guess the almost mental fortitude to use these devices, or maybe they it may lead to further negative outcomes, just sort of like an SES, right? We screen those patients for SES, so I think we kind of have to be also mindful of that when we are thinking about PNS too.
Definitely with the psychological evaluation thing. We were actually talking about this earlier. It's not required in every state. Here in Texas, it is not, whether it's implantable or the more temporary system. But I mean, that will certainly be up to provider and state to state, whether or not it's actually required prior to implant or even for the 60-day treatment. So check your rules.
Hey, great points there. I think before we go any further as well, for anybody that is kind of curious, just defining, okay, so peripheral nerve stimulation, so anything that is outside of the spinal canal, or obviously like brain. We're not talking DBS, we're not talking spinal cord or dorsal root ganglia. But as we may discuss later, and as you certainly see in practice, the periphery starts pretty close. So, there's some people that are using this for treatment of axial neck pain, axial low back pain. So the periphery is basically anywhere outside of the spinal canal. So do you guys have anything else to talk about kind of as far as patient selection criteria, stuff like that?
I think
I think that was, I think, yeah, we covered, yeah.
I think ideally we're looking for somebody with pretty focal, unilateral extremity, stuff like that, and stuff like this, something that you can identify maybe one or two nerves, correct?
Right.
Yes, so the way the Medicare guidelines work for that is they will pay for 2 leads at a time, per date of service. So for example, if you have someone who has shoulder pain that needs to be addressed and but also has knee pain that needs to be addressed, they can have both done within a short period of time, but they have to be done on different service dates.
Yeah. And is there a specific global period where you'd have to address, or are you looking, since they are different body regions, you can
No,
treat
you
fairly
literally can
rapidly?
do it the next day. So the date of service can literally be the next day.
Okay. So where does this really fit into the algorithm? Kind of looking at this, we don't really specifically state peripheral nerve stimulation anywhere on this slide. And I think the whole caveat here that we want everybody to take into consideration is really there's a lot of places that peripheral nerve stimulation can fit in, and that's going to be something that you and your physician colleagues, you and your implanters, kind of help identify what's going to be best in your practice. So, Patrick, where does this fit in with your practice? What do you typically make your patients do prior?
Yeah, so I mean, kind of like you said, more, we kind of have a mix of obviously, new consults that are referred to us from the community specifically for PNS, and then sometimes we find patients that maybe are what we call our legacy patients that we've been seeing for many years, but could benefit from some sort of PNS therapy. Like we were saying, this is sort of for maybe new APPs to the space. This is not sort of a concrete, you have to go in this sort of chronological order, in order to, get, PNS. But typically for our practice, the patients usually have had to have tried some and failed some sort of, conservative route, so physical therapy, acupuncture, PT. Maybe they've tried some of the common neuropathic medication, the tricyclics, the gabapentinoids, maybe possibly opioids, which we know don't typically work as well for neuropathic pain. Our office typically does either one, possibly sometimes two peripheral nerve blocks. I think that this is important because for a couple of reasons. I think that, we were talking about this earlier, but, it kind of builds rapport, right, with the patient, right? If we're planning to sort of temporarily or permanently implant something in them, they want to kind of feel sort of comfortable with the practitioner that will be doing that. Peripheral nerve blocks also can be served or utilized as sort of both diagnostic and, therapeutic. But I think the take home is that just because somebody doesn't have really excellent results with a peripheral nerve block doesn't mean that prognostically that they're not going to be a good candidate for PNS. So we always have to throw insurance in there. So some of our insurance plans here on the East Coast, kind of want to see, has the patient had some sort of nerve block? What was their percentage of relief? Did they have improvement in functionality? And then if they did and it was short term, that's kind of our segue into, okay, let's try some PNS. But I also think too, these injections help, the physician, the practitioner sort of with anatomical mapping, right? You're getting familiar with this particular patient's or individual's anatomy so that when you hopefully get to the temporary or permanent system, if there's any roadblocks or any sort of anatomical variations, this is sort of known ahead of time. There's something on here that, I've had other APPs ask me, is EMGs or NCVs something that, has to be done? And it's not mandatory. I mean, I've seen some cases where practices will do that, but typically, obviously, patients don't enjoy being stuck with needles if they don't have to be. So we don't typically require it. And then I think, neuromodulation, we were also talking about that this is sort of grouping, right? Coupling maybe DRG or traditional SCS. So sometimes there may be patients who failed sort of a traditional SCS trial and maybe would benefit from PNS.
So to piggyback on both of these gentlemen, so the first thing I want to make sure that is clear, which we kind of already said, but for anybody who's new to this is not linear. What we're looking at right here is not a linear algorithm for how things should go before considering peripheral nerve stimulation. I mean, realistically, it could fall anywhere in between any of these beautifully colored boxes. Conservative care can include anything like physical therapy. You can try that. Obviously, medications, neuropathic medications, especially anti-inflammatories. For those that prescribe opioids, that is definitely an option too. The injections, again, although they can be diagnostic or at least bring comfort to both the implanter and the patient themselves, they are not necessary, and nor are they indicative of whether or not peripheral nerve stimulation will work for your patient. With regard to neuromodulation, the only thing that I think I would like to add to that is that, spinal cord stimulation and DRG are both amazing at what they're good for, right? So peripheral nerve stimulation doesn't even necessarily have to mean you failed the other thing. It's as an adjunct for more focal pain, right? Which is what we're really after. And as far as the EMG and the NCS is concerned, I agree. Those things are so painful to do and definitely not necessary. There is no guideline that requires it. I don't believe there's any state that does for sure. But any one of these things can be done. And as far as how many things do you need to fail in order to be able to do peripheral nerve stimulation? Going back to what I said from the previous slide, I mean, it is covered for chronic intractable pain, right? And chronic, although it has definitions by some standards, the truth is that it is basically pain that exceeds the timeline that is appropriate for whatever the mechanism of pain is, right? So it could be 6 weeks out, it could be 8 weeks out, but if it exceeds what should be the pain period, then this could be appropriate if they've failed several of these items.
I think it's in this algorithm, right? It's a continuum. I think for certain conditions, it may be like the first thing you do right after conservative care, or like I said, sometimes it may fall later in the continuum when you've tried some other more advanced procedures. Or there's something maybe additional that wasn't covered by SCS, like Nicole said, or ablations or things like that, or epidurals. So I think that it kind of just is individualized to the patient, right? I mean, I think it falls kind of what potentially peripheral nerve you're treating and sort of where they are on this continuum.
Yeah, I think the only big point is that they have to have tried at least one of these things, right?
Yes.
At least one
Yeah.
for a period of time in order to be approved by their insurance eventually.
So kind of hot topic out there. As far as, for you guys, when we're talking about the treatment algorithm for the patient with facet mediated pain, whether it's, the neck or the low back, stimulation versus ablation, where do you find this fitting into your practice? How do you look at that? Is it patient specific, or is it generally you guys have one thing you do for everybody?
I think it's patient specific. I mean, I think we're starting to see the paradigm shift, right? I've talked to colleagues of ours at other events, and sometimes you may have somebody who young, healthy sort of athlete, maybe that, right? You don't want to ablate the medial branch nerves, and by doing so, you're affecting the multifidus muscles, right? So which continual or ablation destroying those muscle fibers leads to eventual atrophy and destabilization of the spine. So I think that for some, and then other patients, we've done the traditional medial branch blocks times two, and then we've done the ablations, and they just didn't really have great success. So then what we'll do is we'll wait about that 6-month period, for those nerves to theoretically regenerate, grow back, and then we offer them PNS. I mean, I think we usually give like a broad sort of blanket, hey, these are, you've done the diagnostic blocks, you've had success, but temporary, these are some of the options we can do. We can stimulate, we can ablate, and, some patients, like everything, like anything, they some are more, concerned about, burning nerves, that sounds barbaric, or I don't want something implanted. So I think it's catering it to the patient specifically.
Agreed. I mean, I have historically worked with a population that has been doing the chronic pain scene for a very long time, right? So a lot of them have already had RFA at some point. So I feel like, at least for those that have already tried ablation, so that's what I'm seeing mostly is people who have already. If they are, as you continue to ablate the nerves, like you'll find, or at least in many patients that I've seen, that the time of relief will be less and less after each ablation, right? So like after a while, we need to find another choice, and I think this is a great one for it, if it's appropriate for them. But again, it'll go back to all the guidelines we previously discussed as to whether or not it's appropriate. And an implantable therapy may be the ticket, or even attempting something like a 60-day trial first, right? To see if that's helpful to them. And if it doesn't last, but it did help, then maybe an implantable therapy might be useful.
Okay. So leading very much into you have your temporary versus long-term systems. Do you guys want to talk a little bit about the differences between these, other than the obvious one is in for 60 days and one is in for eternity?
Of course, of course. So there are some very important differences between these two things, besides the longevity of treatment, right? The For the 60-day treatment plan, right, to use the temporary PNS, there are things like MRI compatibility that need to be recognized first. To have that system in, you cannot have an MRI during that 60-day period, as we had discussed before. So whether or not that system would be good for you would be could be based on that potentially. Um, but the neat thing about it is that it is a removable thing, right? So after 60 days, you get, you have the leads removed. They're very skinny, very, very fragile little leads
Mhm.
that are put in. And the hope and the research will tell you that once you pull the leads, that there's a very good likelihood that your relief will be sustained, and if it's not, and that's what you tried first, then a permanent system could be great for you.
Yeah, so our practice, I'll say, uses a lot of SPR. So this particular therapy, like Nicole said, 60 days. I mean, and essentially what it's comprised of is you have sort of, an external battery or pulse generator that essentially sits on a mounting pad, which acts as like almost like a grounding pad essentially, and then it conducts the signals sort of through these cables and then to the micro leads that are implanted under the skin. And the big question is, people say, well, if the leads are coming out of the skin, isn't there room for displacement or for them to come out? But the company has come out with sort of these 2.0 leads that are more durable and flexible, and so they're coiled inside, so it sort of prevents migration and the leads from sort of coming in and out of the skin, so it reduces infection. So and then as the leads come out of the skin, they're sort of compact in these little, what are called cradles, and the cradles sit on the back on the skin close enough to where they can connect to this external pulse generator, and then the patient has a handheld remote. They can turn the stim on, turn it off, which is nice, that this device can do sort of bimodal frequencies where you can do like high frequency on one lead, and sort of another stimulation on another, which kind of gives this sort of synergistic effect, which is nice. And it also, you can stimulate muscle versus stimulating peripheral nerve. And the idea, like Nicole was saying, is that after 60 days these wires do come out. But the idea being that having this sort of focal robust sort of signal being sent for those 60 days sort of almost retrains your brain. It like reconditions, you right, having chronic pain results in that ingrained feeling, that maladaptive plasticity, big word. But basically it kind of, your brain is just used to that pain signal, so this focal robust stimulation can sort of decondition that, or sort of, so when the wires come out, you've sort of altered now how the brain is sort of interpreting those pain signals. So, and I mean, we've had where patients maybe can get 6 to 8 months. I mean, the studies have shown sometimes up to 24 months of sustained relief, and you could always repeat it again, which is nice. We've repeated it on patients who have had maybe 8 to 9 months of relief. So it's definitely a very versatile device.
So just to give the bare bones of what it looks like to have a 60-day treatment of peripheral nerve stimulation. So the leads are implanted, of course, and at the end of each lead is it looks almost like a little hook, like a surgical staple that's at the end that kind of hooks on underneath the skin. There is a bandage that is changed out once a week. And at least where I am, our rep is fantastic in helping patients that don't have the support, or it's in a spot that they can't reach, to change these bandages once a week, whether in the office or at another location. During that time, in order to shower, because that's, you'll take off the battery, but you don't submerge in water, obviously. So there's no baths, no hot tubs, no pools, things like that during that 60-day period. And then of course, once you're all done, everything gets pulled and you can go back to normal.
Yeah, I think, and then with sprint, I mean, yeah, and like we said, when the 60 days is up, just as sort of an aside, when you're taking the leads out, like with SCS leads, it's sort of that gentle traction, but sort of, at least what I've done is sort of this like hand over hand, like, because it sort of uncoils. It's almost like a slinky, right? It's like sort of uncoiling underneath the skin as you're removing it. Sometimes it can get sort of stuck, either whether there's maybe some scar tissue or some, so you can either, which I've done before, you can sort of massage the area where the micro lead is inserted, or you can even inject some sort of local anesthetic almost into the tract to sort of loosen it up. There is a chance that when you're pulling the wire out, the tip can sometimes, or a fragment can get sort of stuck or can be remained underneath the tissue. So it doesn't necessarily have to be removed if a piece or remnant is left behind. It's just, something that you would obviously educate the patient that this is a possibility once the wires are removed. And it's something that could just sort of stay there, or sometimes the body can work that piece out. So it's just something to sort of be aware of. It's a little different than taking a stim lead out. And also, if you have something you want to kind of not the direction that the lead is placed, and that's something else that's unique with this system, is that they can position the lead sort of either adjacent to the nerve, perpendicular, coaxial, and so you want to apply just sort of gentle traction the way that the lead was sort of positioned. Obviously, you wouldn't want to go counter traction because it would make it more difficult to remove.
So the way that I do it in clinic, with that, because my hands are small. I don't know about the rest of everybody on this on this call, but I take it like little bits by bit. It can be very tough to pull sometimes, depending on the location and how it was coiled. And you're right, like if anything breaks, if the lead breaks, or even if that tip stays in, I have been told that you do not go in after it. It would be more invasive than just leaving it alone. There's nothing that will harm the patient by having it inside their body. Once they have everything else removed, even if the tip or a little bit of the lead is left behind, they can still have MRI. They just have to let the radiologist know that that's there, so they're not surprised when they find it. With regard to, are we good to talk about the permanent ones now, Patrick?
Yeah, I think that was everything. Yeah, that was everything.
Okay. With regard to the permanent PNS, so as it says, we have 3 different choices that are out on the market right now that are pretty big. Each one is a little bit different in the way that they function, of course, but I think the biggest difference that is actually already annotated is the amount of days for trial. I know that previously with Nalu, I think our trials were like 5 days to 7 days, depending on what your surgeon wants. With Curonics, which was previously StimWave, for those who are familiar with that particular brand, you can have up to 14 days for trial as well. I think the one that is the most different is StimRouter, owned by Bioness. They don't actually have a trial system, right? So your trial can be one of 2 things. It could either be the 60-day treatment, or you can do what they call a table trial, by doing an injection and seeing if it helps, and if it does, then consider putting in the permanent.
Yeah, I think just to kind of go off of what Nicole said, so Nalu and Curonics are both indicated for also SCS and PNS, which is kind of nice because you have sort of more versatility when programming, right? So you can have sort of almost like an SCS but in a PNS body type of thing. So Nalu is sort of has that small micro IPG, which has a life of about 18 years. So, and then the incisions are very tiny, which makes recovery a lot easier. And then getting into the sort of the nitty gritty of the components of it, the outside on the skin, you wear something, a wearable or a therapy disc. which is sort of a circular, almost kind of looks sort of like a hockey puck, but basically connects, beep, 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 connects to the IBG underneath the skin, a little subcutaneous pocket that's made. And the thing which is nice about that device is that, it's the life, right? So it avoids sort of having to have constant battery replacements like an SCS, the pocket, no pocket pain, but also, you have sort of the versatility of, either you can do a single lead, you can do a dual 8, contact leads, which allows to sort of prevent if there's any lead migration, you have more capability with programming. And what's also a positive is that you can do a wear trial. So the wear trial is something where a patient can have this sort of an inactive therapy disc that sort of sits, on the, their shoulder, their knee, whatever body part is going to be hopefully implanted, to sort of see, how they do with the device. So, Stim router, kind of like Nicole said, is sort of put on an all housed in unit where you have sort of the battery, the pulse generator, everything's kind of together, and it sits on a conductive gel pad and then stimulates through the skin to the lead underneath.
So definitely one of the things that I think is true of all of these, whether temporary or permanent, is that there is always the possibility for lead migration, right? Whether it's in for a short term or in for a long term. And that's something to definitely consider with the activity of your patient when you're using it. With regard to the things you were saying about like the way that the outside piece sticks on, what Nalu has, what you were talking about the therapy disc that they use, the materials that they use to put that little wearable disc in is the same stuff that they use for ostomies, right? For those who are not aware, which is very good for those who have a lot of allergies or skin allergies. If they're allergic to adhesives, this is the more gentle of the option, I think, of all of them, the ones that we are talking about today. The other ones you may have an issue with adhesive, depending on your patient and their sensitivities, of course, which is always a risk you take anytime you're wearing something on the outside. But the neat thing about all three, and even the temporary one, is that these batteries, the therapy discs or whatever it is you're using, can come on and off. I think something important to note is that you don't necessarily have to stimulate 24 hours a day in order to use these devices. There are many patients who will, say, stimulate overnight and then wake up and go about their day. And I mean, with the way these should work is that they're getting some relief for at least a part of their day, because of the stimulation that they had overnight. The brain remembers what we've done. We've changed the way that it thinks with any luck.
I think something else just kind of unique to Curonics is that they have what's called like an integrated lead. So the pulse generator is actually sort of behind the electrode, and is actually all one unit. So, you have a wearable just like Nalu, where, you have the transmitter sort of sending these, the energy to the receiver end of the lead, but you're kind of also completing the electric circuit or arc, at the tip of the where the metal electrodes are of that integrated lead. So, I think for those, like physiologically, Curonics, Nalu, pretty much very similar. It's just the mechanism of sort of, Nalu uses sort of like magnetic coupling to transfer the energy from its therapy disc to the IPG, and then Curonics is sort of using more of like a wireless, it has an RF wire inserted into the lead, so it's kind of all compact into one. I think something too, just to be aware of with some of them, is some offer. Like Nalu has timed and non-timed leads. I believe Stim router is sort of a one timed lead, and then Curonics, I think, is also timed. So sometimes it's, we may get to this later, but when patients say, "Hey, is this something that could be ever taken out if I don't like it or I don't want it anymore?" Sometimes just the timed leads may be a little more difficult to take out, but can be taken out. So that's just something to be sort of aware of when you're educating your patients on these devices.
Great overview of all of that. Something that probably comes up often, at least when I'm thinking about this as well, is as far as how do you feel in your clinics and your practices utilizing the temporary, the 60-day as a trial for permanent with a patient that has relief during the time that they have the 60-day device, but then very quickly returns to their chronic pain state. Do you feel comfortable doing that? Do you prefer to trial with the permanent device that you're going to be implanting, or how does that work for you?
That's
Yeah, go ahead, Nicole.
no, you first, please,
Yeah,
Patrick.
I was gonna say that I was actually, it's a good point because for a while when Nalu came out, we were kind of setting up our system or our practice to sort of do the temporary PNS for the 60 days, and then depending upon the patient's response when the wires come out, the leads come out, is to sometimes go to, if it was a short-term interval of time where the pain starts to return, go to a more permanent option. So we were set up kind of very much like that.
So historically, yeah, same, but my mindset personally is changing on that a little bit, and I think it's going to be a patient to patient situation. So for the temporary PNS, for the 60-day treatment, for those that aren't comfortable yet with the idea of something being implanted in them, and we all know those patients, I think that the SPR device is going to be the best fit. Now, if that doesn't work out long term for them, then I think at that point you've created a trust in the system with the patient. So they may be more up for a permanent device. In my experience, and Patrick, please correct me if you've had something different happen, but I mean, the way that these work aren't quite the same. So the efficacy for a permanent implant may feel different to the patient than having done the 60-day trial. Not better or worse per se, but definitely different. They don't always report the same amount of relief. So that's something to set patients up for as well, because it's not exactly doing the stimulation in the same exact way. But depending on the reason why we're doing peripheral nerve stimulation, or even the patient themselves, like let's say, for example, you have somebody who doesn't have the and I've actually had this happen before, where they don't have the support system to be able to change that bandage once a week, or maybe they have dementia or oncoming dementia or whatever, that they'd be concerned that they'd pull the leads or whatever the case might be. A permanent system may be a great go-to, right? I've had families like where they have the family supporting them but not necessarily the time to do all the stuff, right? So they went straight to a permanent, and that was a great fit for them. So I think it will depend to patient now, or at least that's the way my mindset's going.
Yeah,
Like
no,
it's
for sure.
it's no longer an actual algorithm of how to do it.
And I think sometimes too, it's like the idea, right, of or the 60-day therapy is if, you take the leads out and they have quick return of pain, it's like, were they compliant, right, with therapy? I mean, so sometimes I lean on their reps and I'll say, can you assess sort of how, did they have the device on, were they using it appropriately? Were they trying different stimulations, or extending the amount of time, that they had the device on? And I think similarly with all of these, I mean, actually, I think I was talking to my local NALU rep and watching some previous webinars. I think NALU actually is also, I think it's FDA approved up to even 30 days for a trial, but most I think are within that 5 to 7 day range, just because of infection risk. And then again, if they're on anticoags and they have to come off before the trial and then the implant, but yeah, our kind of is individualizing it. I mean, we kind of are saying, and I'll show people, I have all the patients, I have the 60-day system with the EPG and that system, and then I'll have the therapy disc with a little micro IPG, and I'll show them like, this is sort of what the device and the components of this device look like. And some patients are like, oh, I don't know, I don't know about that one, or I give them tons of literature so they can kind of sort of read to themselves and sort of educate themselves about it. But yeah, I think a lot of times, it's also that a lot of what I think we do in the pain world is managing realistic expectations, right? I think that no matter what advanced procedure we offer them, is that this is not going to be the magic bullet, that this is not going to be, you're going to be 25 again, and that all of your pain for, at 85 is just you're going to be 20 again. So I think that it's just realistically saying, hey, if we can cut down on your medications, we can improve your functionality, we can improve your sleep and your overall mood and quality of life. Like those are huge parameters that, hopefully are benchmarks we can hit. So I think that's just for anything we offer is key. So
I couldn't agree with you more, to be honest. I mean, I love that we're having this talk about this device, but it's true of everything that we're doing in the interventional pain world now, right? Like the idea is to get patients off of these medications that they've been on, to offer them something that will improve their quality of life without necessarily, harming other things in order to do it, right? So something like this can offer people the opportunity to get well and hopefully reduce the amount of medications they take, especially as they're aging.
Yeah. And I think just one thing too with a lot of these systems, especially the permanent ones, is that, a lot of the apps that you can use, just like SCS, of sort of, they're on the Android, iOS platforms where, you can kind of, discreetly, change your program settings from a phone. And, a lot of the remotes are sort of very small, very, they're wireless, so these have definitely evolved with kind of the times of, not something bulky or cumbersome. And even the wearables, I mean, that's sort of allowing for sort of flexibility and comfortability when you're, using these stimulators in everyday life.
I think ultimately when you're choosing the permanent PNS for your patient, first, of course, it's whatever support is most available in your region. That's going to play a role in it, of course. But ultimately, each of these offer different nuances that'll be better for one patient versus another. Something we did not mention about Curonics is so the way that they keep their stuff on is that you wear a belt that that puts the little battery on the outside, or the transmitter on the outside. So that might not be a great fit for somebody versus wearing the therapy disc for Nalu may or may not be a great fit for somebody, or if an adhesive isn't great for somebody else, it'll all depend from patient to patient and what you have available at your practice.
I think they're all great.
Very,
Yeah, I think they're all,
Yeah.
they offer something different, somewhat similar, but also different that I think can help such a broad array of patients. So
I think that's something we've gotten really fortunate with in
Yeah.
the interventional pain space now. There are so many options and each one offers their own, their own piece of the puzzle.
yeah. I think what's great too is these are all designed specifically for the peripheral world, whereas, in the past, I know peripheral nerve stimulation has kind of been the ugly stepchild of the neuromodulation world, just, with repurposed spinal cord stimulator leads and batteries that were a little bit more cumbersome, especially for, upper extremity pain or anything like that. So I think it's fantastic that there's such a variety of different options available for patients out there.
And then the one last thing, sorry, more is just MRI. I don't know. I think we kind of touched on it, but MRI, is a big thing too, right? So at the temporary 60-day, while it's in, can have MRIs. Nalu is 1.5 and 3 Tesla head and extremity, right? Correct me if I'm wrong, Nicole. I think in the stim router, it's like very specific. It's I think it's 1.5 and 3 Tesla, as long as like the bore of the MRI is more than like 50 centimeters away from the lead. And then Curonics is, I think, whole body 1.5 Tesla.
And again, it also is dependent on where you're stimulating to. I believe for all of these permanent ones, if it is implanted in the trunk, then you are no longer MRI possible.
Very good to know. Okay, everybody's favorite slide, insurance coverage. How do I document this? What gets in the way of patients proceeding? How do I beat the man into submission so that we can do what we need to do for our patients?
All right. So at least in my practice, I'm very fortunate. But with regard to documentation, I think it goes back to what we're defining as the necessity, right? The medical necessity, chronic intractable pain that has failed conservative therapies. So you need to make sure that you're documenting that this pain has gone on past when it should have lasted, and that you've tried things, right? But be it medication, physical therapy, injections, whatever the case might be, to show that they have failed previous therapies and that this is now the next appropriate step.
Does this need to be neuropathic pain?
Well, I mean,
Yeah, I mean, it's got to be some, right?
There has to be a component of it.
Yeah, I was like, is this a trick question? In the peripheral nerve, I think that, other things that I feel like APPs do pretty exceptionally well is history taking, right? I feel like that's something that we all, take pride in, but I think it's like, have they had prior surgeries? Have they had prior injury, fracture or something to cause some sort of nerve damage? What is the distribution of, of that nerve? Like Nicole kind of said, what we always do. What else have they tried? I think insurance, just generally speaking, Medicare is obviously pretty much a green light, but I think, and then for the regular commercial world, it sort of varies. I mean, and some of these companies have assistants where they can sort of help, you know, kind of get the authorizations along, you know, so which is a great benefit because, you know, how busy we all are. So to have sort of these resources is huge, right? So advocating for the patient. So yeah, I think it's just, you know, again, what's sort of holding up the implant. I think it's going to depend, you know, locally what the guidelines in your state are, you know, what has to be done beforehand. If obviously they haven't tried any conservative care, it's going to be a very low yield that they're going to get approved for a PNS, you know.
So with regard to your question originally, more, does there have to be neuropathic pain? Yes, there has to be a component of neuropathic pain. However,
I
something we
wasn't trying that as a trick. I mean, you do a genicular nerve stimulation for somebody that's primary osteoarthritis. I mean, you can.
Actually, I have to stop you right there because there are instances where, you know, there is arthritis that people are using peripheral nerve stimulation for to try kind of treat that pain, and it really
Oh no,
does.
we've done it very successfully. I'm just saying
Oh
so
yeah.
that, you know, for
No,
that, it's
I think technically, yes, there has to be nerve pain, right? Like you might, or
okay.
at least you must have failed neuropathics. But I think something we have not yet pointed out is that a lot of these systems will end up helping with motor function,
Yeah.
right? So I actually have a patient currently who is doing peripheral nerve stimulation for her shoulder. She's doing a 60-day treatment, and she has had, I mean, it's the lack of range of motion of her left arm has been incredible since I've known her, but she is now able to, you know, open the car door with that arm, and she's able to reach it a little bit higher, and it's never going to be like it was before she had her surgery, and she knows that, but she has like a significant relief of pain and improvement in the way that that arm moves, which is everything to her, you know. And you see that a lot with these peripheral nerve stimulation systems. um what has held up implant? If you have anything to add to what I just said, Patrick, do it first because I've got a few things to add to that. What has held?
I was gonna say, well, obvious, which I think is obvious, but kind of just what else to, you know, document, right? I mean, I think it's just, I kind of touched on this, but right, what are the patient's limitations? I mean, in anything we do or any procedure we recommend, I think it's, you know, pretty key to see or to know, you know, sleeping disturbances, you know, are, you know, affecting quality of life, you know, functionally, you know, maybe they can't work or they have to reduce their work schedule because the pain is sort of so, you know, intense, or, you know, all those things I think kind of corroborate, you know, the need and the necessity for, you know, PNS or really any treatment
Right.
we so.
Functional deficit for sure, for sure. What has held up implant? There's actually a lot of things that can go under this category. I mean, the first is obviously going to be insurance. Currently, the slam dunks are always Medicare and Medicare Advantage plans. Those historically are being approved, no problem. Commercial insurances are fighting it, although on appeal, there have been instances where that does work out. And that, I don't know if that's a regional to regional thing or if that's just here in Texas, but that's currently what's happening. Other things that may hold up the process, clearances from doctors, right? So your off teams and your administrative staff are really key in helping these things along. Like for example, if especially for the implantable therapies, whether or not they have to be off a blood thinner, that's always important to be able to, you know, that has to be cleared by their cardiologist or their primary care, whoever's doing it. Also, of course, proper documentation is going to be key, and you know, your off team in general, getting people scheduled properly.
I think one big thing is the patient too, right? If the patient is sort of, you know, whether they're, I don't want to say flaky, but sort of, you know, they you know, maybe aren't educated enough about the trial or the permanent, you know, at PNS, you know. So I think making sure that your patient sort of is well educated, knows the risks, the benefits, the alternatives. I mean, sometimes that kind of reassures them, right? So if they're sort of uncertain about the therapy or feel like, you know, they're not really so, you know, optimistic about it, I think that's obviously a huge thing, you know, the accountability of the patient too.
I think that's where your reps really come in to help you out, to
Yeah.
help with like, additional patient education. I know all of us are really busy in clinic, and sometimes it's hard to sit for the time you want to tell them all the things that you want to tell them about the therapies that you're offering them. So I know in my region we have a fantastic rep that she's great at like reaching out to the patients and giving them whatever additional education and TLC they need to feel comfortable to move forward.
We do have a question, which is what waveforms are primarily being used? From my experience, has been primarily varieties of tonic stimulation. You have some options of, you know, pulse dosing and stuff like that, but primarily tonic stimulation. So paresthesias, stuff like that.
Yeah, and for specifically NALU and Puronics, I mean, they can do some of the SES waveforms. So sometimes, yeah, you can do high frequency, or like paratherapy is doing sort of different types of waveforms. Yeah, I think they can even NALU can do some almost like burst, so like Abbott. So a lot of similar to SES if they have that capability.
Okay. I feel like this is a slide that we have really been kind of talking about the entire time, kind of guiding the patients through the process, and what to expect, what we're looking for, different treatment. But any specific pearls, other things that you want to share with people, or what are the biggest questions that your patients may pose to you that you think everybody needs to know the answer to?
Yeah. So I thought about this particular slide a lot. And a lot of them we have already reviewed, but just for the sake of, since we're here, is this reversible? Yes, all of them. It's reversible. You could take them out regardless. Whether it's easy or not is another story, but every one of them can come out. Is it covered by insurance? As I said just a few minutes ago, definitely Medicare and Medicare Advantage plans are a slam dunk. Commercial ones, you may have more trouble or maybe not approved at all, but it's always worth a try and always worth appeal for your patient if it's possible. One I get a lot is, can I travel with it? So going through the airport security, and for the 60-day, you can go through the scanners. But you can show your card for any one of these devices and circumvent that and have a different way to go through security. Actually, it is preferred with the permanent ones because there's always the concern for ruining the device that is inside your body by going through them. So, but yes, the answer is yes. It's just a little bit different than it was before. Can I take a bath or go in the pool? We had talked about that earlier for the 60-day trial. The answer is no, you may not. You may shower, but you have to disconnect the EPG. For the permanent ones, once it's in and you're past the healing process, I believe the answer is yes, right, Patrick?
Correct. Yep.
Okay. As far we've talked about the MRI question 1,000 times for but the Sprint device, the 60-day trial, no, you may not use an MRI. And then for the implantable ones, it'll be MRI conditional, depending on where it is, and I guess as far as like scarring or whatever you've got going on.
Yeah, I think another big one we get is sort of what's the downtime, right? I think that's with anything we do, but so that's a big question. What are my limitations? So, for the 60-day therapy, typically I'll tell them, for the first week or so, just avoid any, kind of excessive BLTs, bending, lifting, twisting, or anything exertional, and then typically, piggybacking on that, patients will also say, how long does it take for the therapy to work, right? So I think it's all different, right? I think, again, it's managing expectations where the 60-day therapy, sometimes there are people or patients who are early responders who may get relief right away. And then there are some that are kind of delayed, maybe 4 or 5 weeks in. So I try to encourage patients that give it time, right? They'll come back 2 weeks after and they're like, it's not working, I want it out. I'm like, it's been, 2 weeks. You have to, kind of give it a little bit more, patience, and a lot of the other things, the more permanent ones, right? They're minimal incisions, which definitely has revolutionized the recovery time, minimal, recovery. So, I mean, a lot of these patients are in a few days, a week, able to do a lot of what they were doing pre-implant. So, which is huge.
I get what are the risks a lot. What
Yeah.
are the risks of this procedure? And regardless of whether it's the temporary one or the permanent one, clearly infection is always the thing. It's the moment you cut the skin, that's always an option for it to happen, right? Like, but with great care from all of our practices, it's, it's very minimal. Obviously lead migration is always an issue. Rejection of the device for the implantable one. That is a possibility, not common, but it can happen that the body doesn't like it. But again, as with the original question, is this reversible? Absolutely. So, I mean, it can come out if it doesn't work, or if the body is not handling it like we had hoped.
And I think a big thing we see too is skin irritability from the adhesive. So a lot of these companies offer alternative, bandages or adhesive, whether it's now the clip, or the 60-day therapy where we've changed to sort of a less offensive bandage. So.
It looks like we have a question on our thing. What are the most imaging techniques that can be used for nerve finding, ultrasound, fluoroscopy, or? And at least in our practice, we use ultrasound.
Yeah.
To find the nerve. Technically, there are some of them you can do blind,
Mm-hmm.
although not the preference per se, right? But it depends on what's going on.
Yeah, combination of both. And just as an aside, in the 60-day, we've had this happen, the 60-day, not as much now, but the 60-day treatment, if the lead does sort of come out, we've reinserted it just in the office with local, so under the fluoro or ultrasound in the office and, to restore therapy. So that is something, if the newer micro leads are definitely more durable, but, if the leads come out in that 60-day period, you can, reinsert the lead back in.
We actually had that situation happen just recently with a shoulder one where the axillary lead came out. And so that was just done in office, a little bit of local, and it worked just fine with a little with ultrasound, or it actually can be done without it. So to answer the question, I guess a little bit more succinctly, all of the above, it depends on your practice. But traditionally, I think ultrasound is used. Is that right for you too? Yeah.
Mm-hmm.
Absolutely. So we've educated patients well. Do you guys have any other big pearls that you think of people need to know? I guess moving on to the final thing, like, where do these patients exist? Where are we taking them from? Are these primarily orthopedic patients, or are they, where do you find them?
They're everywhere.
Yeah.
To your answer for the sake of this, the orthopedics is great, obviously, especially for those that have had joint replacement or are trying to avoid joint replacement. It's a great way to help people get more active before their joints are replaced, right? We have talked about that earlier. And a lot of them are sitting right in your practice, right? Like they've had chronic pain and their joints are their back, for a long time. You can get patients from the gynecologist, like pelvic pain,
Mm-hmm.
it can be used for that, or post hernia repair patients are great for this too. So the truth is it's whatever your physician is comfortable implanting, right? And then you find your patients based on that. And your reps are really great at helping you find different referral sources within your community.
Yeah, I think and especially as the indications are getting broader and there's so many more nerve targets that are being utilized now. I mean, I think that you could have neurology referring for, occipital, PNS, or, like Nicole said, we get a lot of gen surge referrals for patients who have had like prior ilioinguinal or inguinal hernia repair, and they've got some sort of either entrapment, ilioinguinal entrapment, or iliohypogastric entrapment, or even there's been some case studies of the 60-day therapy, treating like axial low back pain in patients with multiple myeloma, or I think there was another case study of a physician at a VA in Richmond using it for patients with pre amputation. So they kind of were putting PNS wires in for a few weeks before the amputation to sort of reduce the possible post-phantom limb, condition. So chest wall pain from mastectomies, right? So or some sort of nerve entrapment. So sometimes plastic surgeons will refer to us. So it's huge. I mean, the spectrum is just so broad, which is great.
I noticed that we're probably running out of time. It looks like it's 7:58, but I see one more question in the chat. I don't know if you guys see it too. Is the average pain intensity of greater or equal to 6 out of 10 on the VAS in the affected area and enrollment suitable?
Yes, please do treat that patient.
We'll say it again.
Yes, please do treat that patient.
Yes, absolutely. Right. Like, so the VAS score is just that. It's a subjective pain scale, right? So one man's 6 out of 10 might be another person's 1 out of 10, right? But I think that we can all agree that this therapy is appropriate for anybody who has chronic intractable nerve pain. I think this, regardless of what their VAS score starts at, our goal is to make it as low as possible.
Yes.
Even those 10 plus patients. So yeah.
The one that is 20 out of 10. right? Like
25%.
at least, at
Yes,
least.
Hey,
to the dentist.
I have a really high tolerance for pain. So, just
But,
telling you.
but all kidding aside, though, to your question, whoever wrote this to us, yes, that is an appropriate patient. Our goal is to make anybody be more functional and have less pain.
Yes. Okay. And now we have the reference slide.
Perfect timing. Yeah.
Wonderful. So, thank you, Patrick, and thank you, Nicole, for the wealth of information that you're able to give everybody on peripheral nerve stimulation. Very exciting information. Certainly a lot of patients that will potentially benefit a lot from this therapy. I guess if anybody else has any last questions or any closing thoughts, comments, anything like that, speak now or forever hold your peace, and then we will end the webinar. Okay.
Thank you so much for having us, Nans. We appreciate you.
Thank you, everyone, for attending.
Yeah. Thank you, everybody. Court is adjourned.
Good night.
Good night.